And now I am happy to introduce to you our presenter for today, Ms. Paige Hector. Paige is a consultant, nationally recognized speaker, and author with over 25 years of experience in post-acute and long-term care settings. She specializes in diverse topics for the interdisciplinary team, person-centered trauma-informed care, nonviolent communication, sustainable process improvement, and advanced care planning. Paige writes extensively on topics relevant to nursing homes, including multiple chapters of Managing the Long-Term Care Facility, second edition, due for publication in 2023. She is actively involved in the AMDA Education Committee, the Diversity, Equity, and Inclusion Work Group, and the Behavioral Health Advisory Council, as well as national work groups to improve trauma-informed care. In 2018, she was named the Gerontologist of the Year for the Arizona Geriatrics Society. And now I'll turn it over to Paige to begin the presentation. Thank you.
All right, hello, good morning, afternoon, wherever you are in our country. And thank you, Nikki and the Center of Excellence for Behavioral Health Care and Nursing Homes. I'm glad to be here. So here we are talking about trauma-informed principles, behaviors, and air quotes, we talk about behaviors, I'll go over that, and what it means when we have an activated nervous system. So here's what we're going to cover today. We'll be talking about the principles, and I always will bring into my work how trauma-informed care culture supports residents and staff. To me, we can't do one without the other. We'll talk about triggers and how they impact a person's behaviors, and then how the nervous system might respond when it perceives a threat, and why this is important for us as staff to know. So just a quick recap to make sure we are putting this in context, that this is part 2 of a 4-part series. So there's a little bit of overlap between the sessions because the topics kind of tee up one another. But generally speaking, if you were to go into part 1, these are the topics that I covered in part 1. So definitions of trauma, the many, many different sources of trauma, which we can never make enough slides to cover all of them. Impacts, and we do talk a little bit about reactions and not behaviors, which we'll touch on today. The idea that trauma is cumulative, that we don't just have one event and then it's over and done, that trauma accumulates across a lifetime. The delayed reaction to the trauma worksheet, of course, triggers a bit, and then becoming trauma-informed as an organization. It is not an endpoint, it's an ongoing process. Okay, so let's set the stage about the prevalence of trauma. This really sums it up for me, that even before the relentless stress of the pandemic, trauma was recognized as a widespread, harmful, and costly public health problem. Addressing trauma, an important component of effective behavioral health service delivery. There was even some dollars associated with it. So I do not know if there's more current. If anyone happens to know or finds them, I was not able to. But in 2014, SAMHSA estimated that for every dollar we spend on trauma-informed care, it saves $5 over the lifetime of costs. And when you look at the magnitude of the traumas and the experiences that we are having as a society today, to me, this is very compelling for wanting to bring trauma-informed care into our nursing homes and our assisted living communities. So the Director General of the World Health Organization said, the COVID-19 pandemic has caused mass trauma on a larger scale than World War II, and the impact will last for many years to come. Is that not phenomenal? Just take that in for a moment. That the trauma that we're experiencing post-pandemic, which I'm not even sure that that's correct terminology, it's larger than World War II, and the impact, we're going to be seeing the impact of trauma from the pandemic across generations at this point. So why is trauma-informed care important for staff well-being? And this is where I really am situating a lot of my time and work, is that developing all of us and our capacity and developing systems and processes that are actually trauma informed. That's how we then begin to bring trauma informed care to residents and patients and families. If we do not have staff that have a sense that the workplace, that the environment that they work in, which if you think about the number of hours that staff spend at work, they're more than our waking hours at home. I used to have a slide that had just those numbers, but what I can tell you is that the number of hours for a full-time employee is more than our waking hours typically that we spend at home with our own families. So it really speaks to me how important our families are in our workplace settings. So creating these spaces for us that are trauma-informed is crucial, not just to our well-being, but it's to our capacity and skills to then turn around and create that environment for residents, patients, and family. To me, healthcare staff, these human beings, those of you on this call, have the deepest intentions to care for other people. Mostly, we don't come to this work because we want the glamour and the glory and all of that. It's very hard work. It's gut-wrenching at times. And we come to it with our hearts because we truly have the intention of caring for other human beings. I want to acknowledge that right up front, that to me, nursing home staff especially are some of the most humble and kind human beings that I have ever worked with in my entire career. And yet, only 4 out of 10 employees strongly agree that their supervisor or someone at work seems to care about them as a person. That's 40%. 40%. So how many people do you have working in your community? 4 out of 10 would agree that their supervisor or someone seems to care. Now that's their perception. And that doesn't acknowledge that even if you as a supervisor, a leader, a director, come to your work with the utmost intention to care, the reality is that we have a gap between the intention and the impact. And that gap is speaking to us very loudly. 67% of employees are ready to quit, saying leaders made empty promises. 41% say that they're likely to quit to resolve stress. 25% said they are underperforming due to stress. At no other time have we seen a workforce that is holding more stress personally and professionally than we are today. Emotional exhaustion among healthcare workers is, I think, off the charts, is safe to say. So that's actually a term. I did look it up. I love to look up words. Emotional exhaustion is a chronic state of physical and emotional depletion that results from excessive job demands and continuous hassles. I cannot tell you, since I first looked this up, it's been a while now since I've been working with this content, how many times I personally have thought of it. Oh, the continuous hassles, that not one thing individually is that proverbial straw that breaks the camel's back, so to speak. But when you compile the hassle after hassle after hassle of just getting through the workday and then maybe getting home and the hassles and the things that we're dealing with at home and that our partners and our spouses and our kids. So as a whole, it's just this sense of exhaustion. 40% of nurses, 24% of physicians plan to exit their practice in 2 years. This study, if you notice the date here at the bottom, is from the Journal of the American Medical Association in 2022. So by 2024, this is what they're estimating, as if our staffing catastrophe were not bad enough as it is. The other thing that this study talked about is that it compared 9/11 combat veterans to healthcare workers during the pandemic. What they showed is that equal rates of moral injury. Every time I look at this statistic, it absolutely astounds me that healthcare workers have the same levels of moral injury as combat veterans. There was a study done, this is a northeastern city, and what they did was they looked at nursing facilities greater than 200 beds. And what they found in this study of CNAs, 90% reported at least one trauma in their lifetime. The average number was 3.3, and almost 50% reported physical assault. Oh my goodness, 50%. So imagine this, I just want to extrapolate for a moment. So imagine at a time when not only are staff experiencing enormous amounts of stress, so too are residents and family members. So imagine what happens in terms of trauma. We have a workforce that is extremely traumatized, and a lot of people have had experiences of physical assault. Now we're working in an environment where we all know that at some times people that we are caring for can be physically aggressive or even verbally aggressive. So imagine what that's like to be a staff member, to be triggered and traumatized or potentially traumatized by those experiences, and their nervous system is activated, the resident's nervous system is activated. So what I'm saying to you is that this requires an enormous amount of skill, and why it's so important that we grow our trauma-informed care skills, that we grow our skills to be able to handle situations like this. I also want to put something in perspective. I can't talk about this stuff without at least mentioning something about staffing and turnover. If you take a look here, I want to draw your attention here. So this is turnover and intention to leave over on this side. If you take a look here, influencing factors. So for people who intend to leave the workplace environment, the factors that they cite: work stress, burnout, and job dissatisfaction. So our thinking might be, well, if I can just eliminate those things, if I can get rid of the stress and I can make the burnout go away and increase job satisfaction, then I'm going to have workers stay. But guess what? That's not the case. What they found was the influencing factors. So the intention to stay, that's the retention, people that will stay in the workplace. What that entails is feelings of empowerment, which, by the way, is trauma-informed care, supervisory support, possibility to provide good quality of care. So even if I were to eliminate the factors for people when they intend to leave, if I don't also simultaneously increase the factors to influence them to stay, I've not been able to succeed in having people stay. If you were to look at this slide, this is the work of a colleague of mine that does clinical work with people who experience trauma. Secondary traumatic stress symptoms. Just take a look at this a moment. If you had this as a worksheet in front of you, which ones would you personally be circling? You'll notice that we have 6 categories across the top here: cognitive, emotional, behavioral, physical, interpersonal, and spiritual. So trauma can impact us across so many different parts of our being. It's not just physical. It's so many parts of our mind, our brain, our body, and our spirit. How many of these might some of you be circling? It speaks to me that we can't dissociate our work selves from our home selves. When I come into work, when you walk into a nursing home, you don't just stop and drop everything. Maybe we try to leave home at home, and we try to leave work at work, but we know how sometimes they go into one another. This takes time. And I've really taken to addressing this right up front, because I think people sometimes wonder, how in the world can I do all of this? How can I learn these new skills and integrate these principles when I am already so stressed with what I'm already doing, with all of the things on my to-do list? Folks, I actually do have a wand here on my desk. I'll pull it down for you real quick. I'll show it to you. So I keep it on my desk and I pretend that it might be magical someday, but it's not yet. The reason I tell you this is because at some point, we need to acknowledge that what we're doing isn't working. So it's kind of like saying, okay, what we're doing now is not working. I want to change it. I don't want to continue doing it. And part of that is acknowledging that there's going to be some discomfort as we reprioritize and rededicate where we put our time and how we spend our time at work. So the idea here, a colleague of mine, Mickey Kashtan, she said it so beautifully in one sentence: instead of saving time up front and losing it later, which is kind of our mindset right now, the choice is to invest the time up front and harvest the results later. So I truly do believe that when we can integrate trauma-informed principles, we can do this work. I do believe that we're creating environments that will naturally manifest in ways that will, I'm thinking, reduce the amount of stress, the amount of strain, the amount of triggering people, re-traumatizing people, and the amount of complaints in our facilities. So we're just going to have to resituate and have a different mindset about time. Okay, so there's many different ways to define trauma-informed care principles. This is the definition I enjoy using. And you'll notice I do something different. I've added person-centered here. So to me, it's not just trauma-informed. To me, these are they're very integrated. They're very complementary. So to me, it's very much person-centered, trauma-informed care, which recognizes the pervasive nature of trauma and integrates the principles and practices to promote healing and recovery. So it's not just a thing that we try to complete and say, oh, we're done, we're trauma-informed. We'll never get there. It's an ongoing process. And eventually, what we're trying to get to is a sense that we can create environments that really are healing, not just to the physical parts of the bodies of the people we care for, but also the emotional, the psychological, and the spiritual parts as well. I'm sure many of you, like I do, read McKnight's, the articles in there, and Dr. Barbara is quite a prolific writer. In an article she wrote not too long ago, she wrote about trauma-informed care, and she says, I operate from a belief that virtually every resident coming into long-term care has been traumatized to at least some extent by the health event that precipitated their admission, the medical procedures they've undergone, being away from home, and other losses. And I thought, oh, that just is so true. So just because someone has been, I would even say stressful or distressing situations, just by virtue of being in a hospital and then being transitioned into and moving into a long-term care community, that can be stressful in and of itself. So even if there was nothing else in the lifetime, which is highly unlikely, already we have a person that's potentially at risk of being traumatized. So here's two categories. So let me try to sum it up in a brief way for you. Trauma-informed care is absolutely person-centered. Now I'll go into more of that as we go along. It's a fundamental perspective. It's not just a theory that we apply once in a while. It's a foundational aspect of how we approach our care. It's focused on relationship building and connections, and it's actually a workplace culture. It's not just something that we tack on like a flavor of the month kind of thing. It's embedded in the words that we say, the things that we do, the policies that we write, the way that we run our meetings, the way that we have care conferences, the way that we provide personal care. It's everything. It infuses every part of everything we do. Trauma-informed care is not a training on PTSD. In fact, so many people might have trauma, they don't have PTSD. So they're not always linked up together. It's not just based on a medical model. It's not just a prescribed protocol or some skills that we learn. It's a way of thinking and behaving. It's not just for residents, which I have said so many times, it's for staff, if not more than, at least in the beginning while we create our trauma-informed care environments. And it's not just for people who have PTSD. Trauma-informed care is the practice of engaging others in providing care by intentionally considering the impact of their past experiences on how they're currently showing up, their current actions and words. So that this part here, intentionally considering, that's where I'm talking about, it's a mindset shift that we intentionally consider. For example, this question. This is one of those foundational questions of trauma-informed care practice. A traditional medical model would ask, well, what's wrong with this person? So what that brings to my mind is, well, what's their problem list? What are their diagnoses? What is their admitting diagnosis? So there's nothing inherently wrong with those questions, but what we're doing is shifting from what's wrong to what is the impact of their past experiences on their current presentation. So you'll notice a bit of a difference here for those of you who may have had some training in this area. Some people will teach that it's a shift from what's wrong with this person to what happened to this person. And I actually want to take it a step further. Because if I situate and just say, well, what happened to this person, what that invites me to do is to focus on the trauma events. I'm asking us to take even a deeper perspective than that, a different perspective, that it's not the event that's so important, while it's still important, but it's the impact of how that event is impacting the person today in your facility. So that's the nuance that I really want to bring to this work. Universal precautions. This is another fundamental, foundational perspective of trauma-informed care. So we're very familiar, of course, we're very familiar as healthcare staff of gloving, hand washing, that's the infection control, the universal precautions of infection control. We get that. It's the same idea. So when you think about trauma-informed care, it's gloving and hand washing metaphorically by assuming that everyone has a trauma history, that there's a potential of triggering another person. So if I can just bring that understanding that our life experiences may have been shaped by trauma and adversity, which then impacts us how we show up today, that's a huge shift. And that's the universal precautions concept when it comes to trauma-informed care. A couple more questions you might find helpful. Trauma-informed care is putting the person, the individual, in charge of their environment, their body, and their experience. And there's two questions that you can ask of the person. What would make this experience feel healing for you? Now, let's say, for example, they're coming into your community for a short-term stay, perhaps post-hip replacement. They're going to be there for a few weeks for therapy and rehab, and then go on to wherever they live in the community. You could say, well, what would make this visit? So use the words that match the situation. And then what would help you feel like this is a place you could either live if they're long-term care or come back to? So we're really listening very deeply. So what is it that we can do as staff to modify the environment to help bring about, really this is person-centered, to put them back in charge of what's happening to them and their body, and then to make our environment a place that they really do want to be as much as possible. So here are the 6 principles of person-centered and trauma-informed care. To me, I do a lot of visuals in my work. This is how my brain thinks, how I love to learn, and how I like to teach. This is the trunk. And then up here on the branches, we have all of these principles. So we're going to go through each of these, and I want you to start thinking. It's very simple to say, oh, yes, you know, we want to make sure that we have trust in our buildings and we're transparent and we give people voice and choice and we do person-centered care and we make safety a priority. I completely believe all of that. But what I'm going to ask you to do as we go through this next slide sequence, I want you to really think very carefully about your communities and answer the question, how specifically do you uphold these principles in your community? So what specifically do you and other staff do? What policies do you have in place? What are your procedures and your processes to do this work? So that's really the level I'm wanting to get to with us. Okay, so safety. When we say safety, we might think physical safety. So the physical plant, do we have the equipment we need? Is it a safe environment? Are the doors locked at night? Is the parking lot safe? So disaster planning, do we know what we're going to do if COVID hits again? How do we make, yep, got all that. But it also refers to social and moral safety. So I put some things on there for you to consider. Social safety is the ability to be part of a group. And as human beings, our need for connection and belonging is huge. We saw that, right? We saw that throughout the pandemic, that the impacts of loneliness and how loneliness is the equivalent of smoking 15 cigarettes a day. So to be part of a group, to be listened and heard, to play a role in the conflict resolution, to serve a process. So that's social safety. And then we have moral safety, that it's an environment that integrates integrity, responsibility, honest, tolerance, compassion, peace, and nonviolence. So that really speaks to me of staff's experience of what is it like to be an employee in your community. Speaking about staff, I want to just touch on that for another moment. This is a wonderful article. I've got the site there. It talks about creating a safe environment for staff. Effective teamwork depends on two things: team members' psychological safety, specifically defined as their ability to trust and to feel safe in the team, to admit a mistake, ask a question, offer new ideas or data, and to try a new skill without fear of being embarrassed, shamed, blamed, punished. It also allows team members to learn and teach and communicate, reason and think, and all of these things. So when we talk about staff safety, this is where I would love for you to refer to and ask yourselves those critical questions. How are we doing this? What specifically could you ask your staff? What are we doing to help you feel like this is a place that you want to continue working? So what I'd like to do here is I challenged myself as I was recreating this content. I wanted to bring it alive for all of us and use a specific example. So what I decided to do, I recently wrote an article for Caring for the Ages, which is the Society for Post-Acute and Long-Term Care Medicine, so otherwise known as AMDA. So this article, it's free. All of this stuff is free, open access. And what I did here was I wrote a piece about how do we apply trauma-informed care principles to one specific area, and I chose weight stigma. So what I did was I took this article and I want to show you how to operationalize these principles and make it very granular for our residents and our patients. And I would actually say as our staff as well. Trauma-informed care safety consideration for people with larger bodies. Now you'll notice right away, I'm not saying obese. I'm saying people with larger bodies. So part of becoming trauma-informed is noticing and attuning to the language that we use. So do individuals of all body sizes and types, including families and staff, feel safe? And how do you know? So it's one thing for me to say, oh yes, I'm sure people feel safe, but it's not enough. Go ask, how do they feel safe? Are people well trained to do their jobs? Do they have adequate supplies of equipments and beds and commodes and showers and Hoyer slings and all of this equipment that we need for human beings with larger bodies to help instill safety and dignity and trust? Do they feel like they are actually part of a group, that they're heard, that they belong? Have you completed a community assessment, which includes residents, and I would also say staff if they're willing, staff with larger body sizes and family members, to give us the feedback that we need to know to really make our communities safe? What do you identify as areas of unmet need and what's going well? Remember to always look at what's going well. Have you created weight-inclusive environments that focus on well-being for anyone, not just areas of weight? And do you encourage healthy behaviors without even mentioning size? So this is just a smidgen of how to apply these principles of safety. So we're going to do the same for the other ones. So trust and transparency. This is really, if I can integrate, if I can bring safety, empowerment, voice, and choice into a community, I'm going to have trust. See how they're all woven together? They all go together. So when we work with people, there's no really, we might have things that we want to accomplish when we speak with them, but there's really not a set agenda. We're open and truly willing to listen to them, paying attention to their comfort and their nonverbal cues. Transparency is that we do what we say we're going to do, and when things don't work out, we acknowledge responsibility. It's not blame. I want to distinctly untie the idea that when we have responsibility, acknowledgement of responsibility, that somehow we're to blame. That's a big misstep in our community, in our training. So transparency is that when things don't go as we had hoped, that we are open to talking about them. That's transparency. So how do we do that with people with larger bodies? Well, ask some questions. Do people feel safe to be vulnerable in your community? Do they trust that medical providers and that they are willing to share personal information, which may include feelings of shame? Are daily operations and decisions made visible and predictable? Have staff been trained on how to cultivate empathy? And I put a definition, and I won't be going into too much of the empathy and nonviolent communication, but to develop trust with people is empathy. It's empathic listening and communication. Do we talk transparently? Do we talk about these things like weight bias and strategize how to do things differently, how to address it in our facilities? We let it become a discussion point. We talk about it and we listen. And then rather engaging in an anti-obesity campaign, focus on what we want to do instead. We want to focus on eliminating weight stigma. That's what creates the trust and transparency. So often we tend to focus on what we don't want instead of what we do want. So I'm asking us to switch that around. So empowerment, voice, and choice, that we recognize people who have lived through trauma often feel like their power has been stripped away from them. So trauma-informed care is how to put people back into a sense of having a sense of power, of true power. Recognizing and building on people's strengths, self-determination, not coercing and demanding people to do things. Giving voice to people who have historically not had a say, and shared decision-making. So all of these are qualities that embody empowerment, voice, and choice. So how do we do it for people with larger bodies? Does your facility culture cultivate the conditions for people to share feedback in a way that's experienced as safe and comfortable? So if people share feedback that they don't feel safe and comfortable in their community, are they met with true empathic listening? Or is it, well, we do a good enough job, or we got that larger thing for you, or is it argumentative in nature or defensive? Are people comfortable saying no when asked to do something they don't want to do? That's a huge clue if people feel empowered. Do we integrate a strengths perspective? Do we recognize that power and privilege? So folks, as staff members, and I'm pretty much guessing that people on this call have a lot of power, we need to recognize that there's a differential. So we need to recognize when we're coming at a human being with a power over agenda, and coming at it with power with, that we're sharing power. Teach and model person-first language. So instead of saying that's an obese patient, say and document patient with a larger body or a higher weight. There's a link here. There's criteria for treating people with poor metabolics. What I'm trying to say here is that there's an association for size, diversity, and health. In other words, we don't just assume that a person with a larger body has a problem with that, or that they're not healthy. So there's some very clear clinical indications for that. And that's what that resource is for you there. So peer support, the idea that people with similar experiences can have a sense of solidarity and support and healing. Now, that does not mean that we go around asking everyone with larger bodies to join up a peer group, right? So there needs to be some tact and some consideration of how to go about doing that. Ask questions. Would they enjoy people? And it's not just about the experience of having a larger body, but experiencing connection with other people that share similar experiences, maybe having experienced weight stigma. Are there ways to share life stories and experiences that cultivate empathy and compassion and understanding? Are there community-based groups that we can connect our residents with that are outside of our nursing homes? And then what other resources are available? Attention to cultural, historical, and gender issues. So this is the trauma-informed care principle, self-awareness of bias and stigma and discrimination. This includes our policies, procedures, and protocols, that we attend to humility and curiosity, and that we recognize and address the historical nature of trauma. Basically, what that means is that even events that happened, like for example, Holocaust survivors, while that number is diminishing as these individuals die, the effect of it through their generations and through families, through children and grandchildren and great-grandchildren, the impacts of that experience, and it's the same for people who experienced slavery and genocide. It will be the same for people who experienced the firsthand effects of the pandemic. That's called epigenetics, that the trauma transmits literally through our DNA across generations. So when we talk about people with larger bodies, have they been included in the facility's DE&I plan? Are there trainings to eliminate weight stigma? Remember, not anti-obesity, but eliminating weight stigma. Does the DE&I plan seek to create inclusive environment? Are there policies that respond to these things? So folks, there's tons of information on these slides, but I'm going to get us next very quickly because I do want to talk about the nervous system. So again, collaboration and mutuality. This is the 5th or 6th one we're talking about with the principles that everybody has a role to play. It's not just the social work department or the admissions department. It's everybody. That we support decision-making and we level power differences, which I alluded to a moment ago, that when people have less power, and I listed specifically some of the groups, the global majority, which is people of brown and black skin, that is the global majority. People living with disabilities, older people, people with larger bodies and lower different socioeconomic status. Individuals, when they do not have the power that it's enjoyed by other people, they're less likely to know what they need. Either they won't know it or they're not going to say it because they don't trust. And we are trained to not say anything about what we need. So how do we do this with people with larger bodies? Do we actively cultivate the conditions to include everyone? Do we tend to the power differences? And have we reviewed the care plans of residents with larger bodies and weights? And what do the goals and the interventions tell us? So there's some content here you all can look at. This slide here just really, it addresses the idea that healthcare is very much a domination type of system. And I'm not putting blame or anything like that on it. I'm just simply saying for what it is. In healthcare, a traditional medical model is very much centered on hierarchical, how our facilities are structured. It's about control, it's about rewards, and it's about punishment. What we're trying to move toward with trauma-informed care principles is something based on partnership, moving towards care and authenticity and empowerment and voice and choice and peer support and collaboration. That's what we are moving towards, and I do believe that we're making inroads into that. The less trauma-informed that we are, the more likely we are to contribute to situations that stimulate reactions from other people, which is being called triggers. So triggers are reminders of dangerous things or frightening things or people that have experienced in the past. In the past can be the day prior, it can be 80, 90 years ago. They can come without warning and be absolutely anything. A sight, a smell, a way a person looks at you, a particular social situation, a seating arrangement. There's an infinite number of ways that people might become triggered. And what's really it's really difficult is that we may not even associate the trigger with an actual event. It can come out of the blue and completely take us off guard, or the person that we're maybe providing care with. All of a sudden we were doing fine, and now this person is either striking at us, yelling at us, or doing something, or completely shutting down. And we're like, I have no idea what just happened. It's very possible that could be a trauma trigger. What happens is that when we interpret the environment to mean that we are not, we're maybe not safe, we've been triggered, I'm not safe, I cannot protect myself, I literally could die, or I don't matter. So when we are feeling triggered, this is what our body and our mind are telling us that could possibly happen. And when a person interprets their environment in this way, that their body is saying, you are not safe, something bad's going to happen, and you, by the way, you don't matter, they may do things or say things that we as staff find really super difficult to be around. Okay, we label them as having a behavior descriptions. Well, that's inappropriate behavior. I've read so many care plans over my career, inappropriate behavior. We talk about behavior monitoring and tracking and care plans, and we have behavior management teams. What I'd like to do is switch this up a little bit, folks. I really want to undo and understand that when people react in ways, especially ways that we do not enjoy, they are not having a behavior. And I'll tell you what it is instead in just a moment. A behavior is simply the way that we act or conduct ourselves. It's something that we can see and hear. Literally at this moment, I am having a behavior. I'm speaking, I'm teaching, I'm talking, I'm using my hands. It's something that you all can hear and see. So behavior in and of itself is not inherently good and bad, right or wrong, or appropriate or inappropriate. If we can get rid of those descriptions, those are judgments, okay? And shift ourselves to this instead. Instead of behaviors, they're actually reactions that may in fact contribute to challenging care situations, absolutely contribute to what's very difficult to be around. So this is a list. I know we can make many slides of all of the things that we do, that people in our communities, and it's not just residents, it can be us, that other colleagues and staff and supervisors, that people in general do, that other people may find challenging. But here's the thing. With a trauma-informed care lens, if you can understand these as coping mechanisms that made perfect sense at the time of the traumatic injury, we can bring more compassion and tenderness because it was an attempt to survive a situation that at the time it made perfect sense to survive, even though these are coping skills, are probably not serving the current situation. And that's the really tough part. I want to untangle one other thing, that just because a person is triggered doesn't necessarily mean that they've been re-traumatized. So untangle those, okay? Re-traumatization, the best I could explain, the best that I've seen it explained was by Dr. Gaber Mate. He says it occurs when a person is rendered psychically or physically more limited in a way that persists, re-traumatized. Now, I do want to show a handout to you, and this is something Nikki's going to make available. This is one of the coolest ones that I've seen in my work. This is available to you. It's free of charge. It's a wonderful tool to help us understand when actually from a system perspective, so over here, it's at a system level and a relationship level. When these things continue to happen over and over, that actually can be received and experienced as re-traumatizing. So what do you do with this? Please download this, use it in your trainings, talk about it, ask your staff, ask residents. This is how we can begin to make a difference. Okay, take a sip of water. Okay, I want to just briefly talk about the nervous system response and why this is so important. When we are triggered, when something happens in the environment that our brain interprets as, you are not safe, something's going to happen, you could literally die, or you do not matter. What happens is our amygdala is now on fire. It is lit up in that little part of your brain. It's about the size of an almond. It is on fire. And what its purpose is to help make sure that you are safe. It's perfectly positioned to literally shut the part of your brain down that has the ability to rationalize and to think and to problem solve, because everything that your body and brain are doing is doing now to keep you safe. That's what your amygdala does. This is where your memories are stored. And why is that important? Every second, your amygdala is, right now it's doing it. It's scanning the environment. And look at the numbers here. This blew my mind. 12 to 100 times per second, asking a question, relatively speaking, like this. Am I safe and do I matter? Am I safe and do I matter? 12 to 200 times per second. Your body is scanning the environment to make sure that you're safe. So if anything triggers you, a smell, a sight, a taste, a sound, a word, a social situation, a look of a face, that memory that associates something in your past has been stimulated or activated, that your brain is now going to interpret, I may not be safe, or I don't matter anymore. Okay? Your nervous system might go into one of these states: fight, flight, or freeze. We're pretty familiar with these, but when we're in a fight, literally our body is gearing up to say, I am going to yell at you, I'm going to punch, I'm going to do something, I'm going to get defensive, I'm going to use my energy to fight. It might come across as non-compliant or combativeness. When a person flees, they are literally it's withdrawing, disengaging, and it's avoidance, denial, drug and alcohol use. They are checking out. The freeze state might have come across to us as staff as a person that's passive or unmotivated. They're shutting down or disconnecting. They might have trouble tapping into what they're feeling and what they need. I want to introduce you. This is the first time I'm doing this, and I'm going to do it with you all today. I want to introduce you to another concept. This is the work of Sarah Payton, and what she talks about is there's actually another state: fight, flight, and freeze, and alarmed aloneness. Alarmed aloneness acknowledges that how relational human beings are, and that we become actively distressed when we are worried about someone we love or about being alone. And that our experience, it's not anger, it's not fear, it's a distressed and activated grief and loneliness that is not named or acknowledged. Take this in for a moment. Have you ever felt just so frightened or in a state of grief that you're not angry, you're not wanting to run away from a situation or shut down, but there's just something else? There's a very good chance that this is what you are experiencing. Whether it's fight, flight, freeze, activated aloneness, when your body gives the message, and there's just a few here, that there's some distress. My pupils dilate, my muscles go tense, my posture changes. Either I slump down, which indicates shame. I grow big, which might indicate fight response. Repetitive movements. There's so many things that our bodies do that give us information about what's going on internally. So as staff, if we can begin to be more in tune to the clues that residents are giving us, to me, this would be a lovely part of trauma-informed care training, because what's happening is that when we are below the line of choice, if you can imagine, here's the line of choice and we're below, we're in a state of mobilization or immobilization and activation. So fight, flight, freeze, and alarmed aloneness, which I will start including, we're below the line of choice, meaning we do not have as much access to responding to a situation because we're in reaction mode. We're going to yell, we're going to fight, we're going to shut down, we're going to go into a state of depression or worry or grief. When we go above the line, let me get this here. When we go above the line of choice, that's where we're more engaged, connected, we're grounded, we're settled. So we recognize that when we are over here, the fight, flight, freeze, and alarmed aloneness, and our brain is saying, am I safe? Do I matter? Am I safe? Do I matter? This part of our brain over here, the front part, the prefrontal cortex, it shuts down. So all of these things over here go offline. So imagine telling someone who's agitated or shutting down or disconnecting, dissociating, either come on, perk up, or calm down, calm down. That ability is no longer available to them because their system is stimulated. So it doesn't work. It probably actually activates them to do more of what we were hoping they would stop doing. So the fear modulation part is a huge part of being stimulated when there's a sense of alarmed aloneness. There's a lot of fear. So when we're in that state, it's very difficult to get ourselves to go above the line in groundedness and connection. So when memories in the amygdala, they're not time-stamped. In other words, there's no clear sense that the memory, that the situation has ended or that it's over. The body is still going to react in the same way. So I'm going to give you an example here, actually two different examples. A person is attacked as a young adult, maybe a child, by a dog. And then now they're in your community and a pet therapy dog comes into your community. And this is the most lovely, gentle, darling, sweet dog that just will sit so quietly and would never hurt a flea. This person who's had this memory in the past of being attacked by a dog, that memory was stamped into their brain, their body, their mind. That's what trauma does. So even though there's no danger from this dog, that's not what their body is telling them. They may exhibit incredible fear, even though there's no danger. Their amygdala has sprung into action because of the imprint of that memory as a child. Okay, so telling that person, oh, Mrs. Smith, this is Lucy. She's the sweetest dog. She never hurt you. Lucy's not listening because her body is saying, oop, I'm not safe. I am potentially, maybe not going to die, but I'm in danger of being injured. A person that was in an abusive relationship, Very little choice, which we know in abusive intimate partner violence. A lot of times there's very little choice, that they're told what to do, when to do it, how to do it. So this person is now a resident in your community. They are told, and we, even though we try to bring as much person-centered care and choice over scheduling, this person receives a message from staff that their shower days are these particular days. Okay. That may stimulate something in them that reminds them of the experience of being in that relationship. They either shut down and completely give in because that's how they survive, or they explode on you. Either one of those is a coping strategy for what they experienced. So this is how we begin to bring that trauma-informed care lens, that when we have a situation where we are with a resident or a family member or a staff member, and they are doing or saying something that's so puzzling that we can't quite figure it out. If you can begin to think about, could this be related to something that happened in their past? I know for me, when I'm able to do that, and it takes practice, this does not happen overnight, you open up a possibility of a bigger capacity for compassion for another person. Because we understand this is, I love this analogy. Sarah Payton is just brilliant when it comes to the analogies and visualization. Masses of associations that form vivid memories of emotionally significant seconds in a person's lifetime, they become a glacier of experience, triggerable at any moment. I thought, oh, this is a beautiful visual. So all of this indicates all the memories of all the memories of your lifetime, all of those emotionally significant moments throughout your life that can become triggered at any moment. It might come across as a lurch, like the ice that's breaking off here, where it's a sudden rage, unexpected tears out of nowhere, and you have no idea what's going on, or maybe you do. Out of nowhere feelings that don't seem to make sense. Or it could also move very slowly, the glacier as it moves very slowly, that what might show up with our residents as not wanting to participate, isolating, declining care, doing things that might actually sabotage their own well-being or have a negative impact. So those are things that could be happening that might indicate that they're triggered, there's a trauma history. So the power of the amygdala here, I want to just do a little excerpt with you, a little story. Imagine a woman that moves into your community following hip replacement surgery. We can all identify with this. She was found in her home after being on the floor for 4 days. The mail carrier, as they often do, sounded the alarm. She was laying in a crumpled body position, a puddle of urine and feces and very strong odors. The phone is just out of reach and it's ringing intermittently until it dies. There's a pet whimpering with fear and hunger. The pressure of the walker that's stuck beneath her body, the feel of the cold tile in her face, and the horror that she could die and die alone. Other intense emotions like the shock, the pain, the terror, the confusion, the grief. All of those memories that I just described to you, all those sensory imprints, those have all been imprinted in her mind that she may or may not even be aware of. Remember, the amygdala, 12 to 200 times per second. Am I safe? Do I matter? Am I safe? Do I matter? So now she's in your community and you go in and you are going to go in and provide care for her to assist with ADLs or a PT eval or a psychosocial history or whatever it is. You go in and all of a sudden you do or say something, or somehow she is triggered that catapults her body, her brain, and her mind to that situation when she was on the floor in the puddle of urine and the pet is whimpering and the cold tile and the walker beneath her body, and she's terrified. So this is what's happening. This is the power of the amygdala, the memories that are stored there, and how we as staff can inadvertently, with zero intention of causing distress for anybody, because remember, human beings, as a healthcare staff, as human beings, we bring the utmost care and tenderness to our work, but this is how these things can happen. So here's 2 questions I want to leave you with. When you encounter situations where it's befuddling or puzzling, ask yourself, How could this behavior, remember, it's just things that people say or do, not behavior like we're used to using that word. How could it make sense as a reaction to a past trauma? And what might this person need to avoid reliving their trauma in the future? With that, I'd like to invite you to use the chat box, please. I would love, what is one little thing that you're taking with you today? What's one little thing that you might take that you're curious about that you might try to integrate and talk with staff about in your community? So with that, I will keep my eyes on the chat box. Nikki, I'd love to open it back up to you. I will just thank you for being here. Thank you for making our communities more trauma informed. And if there's anything I can do to help, I'm available. This resource here, and I know, Nikki, you need to get me to here. Okay.